All right, we're back. We have Terrance Sgroi. Terrance, thank you for coming on. Can you give the listeners a background on yourself and what you're currently doing?
Sure. Thanks, Chris. Thanks for having me. Always excited to talk about this topic. So yeah, I've been a physical therapist for almost 20 years now, which is really hard to think about. Things have gone super fast. And, when I graduated PT school, I always wanted to work in sports medicine in some capacity. But I started working in a general outpatient orthopedic clinic. And one of the doctors that I worked with was one of the older physicians for the Miami Marlins. And he sort of took me under his wing, and that's where my love, I think, for shoulders started, when he started to show me all the intricacies of the joint. And I sort of realized that rehab was a little difficult for some of these shoulder patients. So started really in outpatient ortho, general experience there. Moved to Chicago for a couple years to work in Chicago, and I was able to work with a lot of the physicians at Midwest Orthopedics at Rush, and continue working on shoulder patients, and sort of morphed into more of like a baseball focus while there. And then came back to New York, and now I work at Hospital for Special Surgery on the West Side in our sports medicine center with those physicians, and help organize and coordinate a lot of our upper extremity rehab there. So yeah, it's been over the last 18 years, definitely have stayed in the outpatient world, but now focused mostly on shoulders and elbows. And that's probably about 99% of my caseload. So it's been great. And then having an opportunity to consult with some major league teams and work with some baseball players, and really constantly learning. So I went to University of Scranton, got my master's there, transitional doctorate through University of St. Augustine, and some of Dr. Stanley Paris's work, and got certified in manual therapy, and then got my SCS a few years later. So trying to always learn and find, people that can help enrich my understanding of certain topics. And really, the shoulder and elbow have been a focus of mine for at least the last 15 years, definitely the last 10 that I've been at the hospital for special surgery.
And the topic for today is going to be largely based on your paper that came out in 2018, but the topic of rotator cuff repair, this early to mid stage rehab process. And we were talking before we recorded how, at least in my PT program, but this seems to be a recurring theme with the PTs in my clinic and just younger new grads in general, this uncertainty around how to progress a patient post-op rotator cuff repair, and how conservative versus how aggressive to be. And your paper, we'll link it below, was very helpful, at least in our clinic, of guiding decision-making and logical steps throughout the week and months, early to mid phase. So let's start, Terrance, with diving into what even are the rotator cuff muscles and their purpose and actions. And then we'll kind of go into rotator cuff repairs and then the post-operative rehab. So let's
Sure.
start with that first question.
Absolutely. And I hope my paper's still relevant. I'm trying to think back to 2018. I feel like I've changed some of my decision-making process, but we'll definitely get into that. So yeah, the rotator cuff, as you learn in school, four muscles that form the cuff. So your supraspinatus is up on top. And then if you go around the back, you have your infraspinatus, teres minor, a little smaller, but also on the back side. And then the front side, you have your subscap. And the role of these muscles, so if you take them in isolation, the supraspinatus is an early elevator of the arm. So it initiates shoulder abduction elevation, really the first 30 to 60 degrees before that deltoid kicks in, and that's the supraspinatus. Going around the backside, you have your external rotator. So your infraspinatus and your teres minor are largely external rotators of the shoulder. And in the front, you have your subscap, which is an internal rotator. And I think that the prime goal or function of these muscles are really not their isolated movements, but the fact that when they work together, they act as dynamic stabilizers of the arm. And I think that's really what attracted me to the shoulder, is when you think about the shoulder joint in general. And when I explain this to patients, I try and make this as simple as possible, is that your shoulder is a ball and socket, like a golf ball and a golf tee turned sideways. And if there was nothing holding it in place, everyone's shoulder would dislocate. So we have these layers of tissue that help provide stability. And of course, you have your static stabilizers, which are your labrum and your capsule. And that alone is not enough. Then you have that next layer, which is really the dynamic stabilizers in the rotator cuff. And it's truly amazing that when these muscles work together and they're balanced, they hold that golf ball in the golf tee or on the golf tee, but then you can raise your arm and your shoulder moves in so many different positions. But those cuff muscles have to be working perfectly to do that. So the primary function of them for me is really dynamic stabilizers. They hold the ball in the middle of the socket as you move your arm. And I think that's what people don't appreciate enough, is that they truly are dynamic stabilizers. If there's something wrong with that group of muscles, then it throws off the function of the shoulder. On top of that, they obviously provide rotational motion. And then for our athletes, they're force transmitters. So we talk about the kinetic chain all the time and how we develop all this power in the legs and transfer it up to the upper extremity. But all of that force and power has to go through the rotator cuff as well. And whether it's somebody, going back into external rotation during a throw or decelerating the arm, those muscles have to work very, very hard to transfer that force from the lower to the upper extremity. So they've got a lot of roles. And I think that it's more than some of the stuff you just learned in school where they're primarily external or internal rotators. But they all do serve a very specific role in the function of the arm, especially for movement.
And the goal today isn't to discuss the time when rotator cuff repair is warranted versus non-surgical management versus all the complexity there. We're going to jump to someone's already received a rotator cuff repair, and we're not making this decision of whether or not it's warranted or we should delay that process or not have it occur. So that will be potentially for another time, but let's just go straight into it. For rotator cuff repairs, what are the most common procedures? And that may depend on the age and the athletic population versus older adults. But what are most common repairs performed?
Yeah. So I think when I started, almost 20 years ago, single row repairs were relatively common. And then now I've seen more double row repairs. So very simply, and again, this is more of the surgical, technique discussion, but so I'll keep it very brief as I'm not a surgeon. But single row repair, if you just think about it, as the cuff comes and attaches into that humerus, there is one row of anchors. So say two anchors on that lateral side that take the cuff and then hold it down to the bone. Then there's a double row repair, which is just an additional row of anchors. So there's a medial row of anchors and a lateral row of anchors. And if you can envision that, what it does is it causes or recreates a broad footprint on that humeral head. So if you look at some of these anatomy papers on the rotator cuff, and you look at footprint papers, there's papers that show the actual footprint of the rotator cuff on the humeral head. You'll notice that the footprint of the rotator cuff is quite broad. So it's almost like a postage stamp footprint. It doesn't just come in over the top and attach linearly, but there's a broad, flat footprint. And the double row repair does a better job at recreating that flat, broad footprint. And if you look at the literature, double row repair almost always outperforms single row repairs in those medium, large, and of course, massive repairs. They also talk about a transosseous repair, which I don't see a lot of, where they drill holes to the humeral head, but I'd say most common ones that you'll see will be single row and double row. A single row may be more in the smaller, like if it's a real small repair, but most of those large and massive ones will be double row repairs. But I think that also brings up an opportunity for you to discuss with the surgeon when you're seeing these patients. And we're lucky enough to have everything in our own medical system for our physicians. So, and we can get into this later, but knowing what exactly was done for each individual patient you see, I think has been critical in my rehab process. Because you're always trying to figure out if it's someone that you might want to accelerate a little bit or someone really need to take your time with. And then especially what type of repair. So someone that had, if it was a large tear, but they had a single row repair, I'm probably going to take them a little slower, knowing that they don't have that additional, row of anchors.
And which rotator cuff muscle and tendon group is the most commonly repaired, or which group of them?
So typically supraspinatus. I'd say majority of the rotator cuffs that I have seen repaired have been supraspinatus. That being said, again, talking to your physician, because there will be times where you have a large tear that extends back into the infraspinatus or extends in the front, and you might get a script for rotator cuff repair, but they might have repaired the subscap. And just looking at some of the portal placements, you're not going to be able to tell. So I think understanding exactly, I mean, granted, most of the time it's going to be supraspinatus, but understanding that it could be a subscap repair, or it could be a large supra infra around the back or multi-tendon repair. So, if I had to guess when the cuffs come in, I'm going to guess supra, but, it could be all three of them.
And how often are you generally seeing other repairs with that, like a bicep tenodesis or other surgeries within the repair?
Yeah, that's a good question. I'd say the trend now over the last probably 5 years has been to tenodese the bicep as well. So some of our physicians that I work closely with, some of our middle-aged to older population, the bicep. So also, if you look at the anatomy, the bicep tendon comes, right up the front of the shoulder, dives deep into the shoulder, but it comes under that acromial arch as well. So sometimes the bicep is actually producing or causing some of their pain. So when the surgeons go in and they see that the bicep is all chewed up or partially torn, they'll usually tenodesis. They used to just tenotomize it, where they'd cut it and leave it, and you've got the second attachment on the coracoid. But more recently, they've been tenodesing it, and that's also something you need to talk to them about. Usually, they'll have some of our physicians will do like a subpec tenodesis. So you'll see when they come in a small incision right by the armpit or the axilla, and that's from the tenodesis. What that will do to your rehab process is typically we will avoid loading the bicep for 8 weeks. So we'll let them actively move their elbow in a neutral palm position, but we're not going to load them. So I tell them no more weight than a cell phone in their hand for the first 8 weeks. Just so the bicep tendon, that anchor placement, can heal, because the last thing you want to do is stretch that out. Other things that we'll see done at time of surgery, so subacromial decompression is pretty common, right? So if they've got that hooked acromion, or if they have bone spurs on the acromion, they'll usually shave those down, create a little more space in that subacromial area. And then I'd say maybe 5-10% of the time at most, there's a different tendon involved also, whether that's infraspinatus or subscap. Definitely seen more subscaps over the last couple years. And I don't know, if there's a reason for that, but yeah, we see all of it. But I'd say mostly supra. Most common thing I'll see is supraspinatus repair, bicep tenodesis, subacromial decompression.
You just discussed some of those considerations for if they have a bicep tenodesis, not really doing anything externally loaded outside of the weight of the arm or a phone. But if they're coming in regardless of the repair done, what are early complications that you're considering and discussing with patients on day one or even pre-ab wise?
Yeah. So for our shoulder patients, typically I'll see them at the 4 week mark. So sling is on 4 to 6 weeks. When they come in at week 4, I mean, and again, prior to seeing me, they'll go in to see the surgeon at about 7 to 10 days for stitch removal. And when they see the physician, they're typically educated on some sort of postural exercise, whether it's just like standing upright, scap retractions, just some very light elbow flexion. And then at that 10-day mark, usually just like a passive shoulder, I say elevation, the scapular plane to like 50 degrees. So just moving the arm away from the body, um, using assistance from the other arm. So completely passive. So I'll see him at 4 weeks. And what I typically see at 4 weeks from, like, say, complication side, or the things that I start to, have a high alert for, would be like nerve issues. So depending on where the sling was, I've seen some people come in that have like paresthesia in the fourth and fifth digits. So sometimes the ulnar nerve can get irritated, just the way the arm's sitting in the sling. What I also don't like to see is someone that's been in like constant pain. So over the course of 4 weeks, or 4 to 6 weeks before you see them, that pain should gradually decrease. So if someone comes in to see me 4 to 6 weeks and like, wow, this has just been like increasingly sore, then I start to wonder what they're doing at home, right? I think of some of those patients, they do more than they should. I don't think that they truly understand what was done during surgery. So I think education is critical, especially in those early, 4 to 6 weeks when we're not monitoring them as much. But I'd say, so pain that does not start going down, and granted, they're not going to be extremely comfortable at 4 weeks, but pain should be decreasing. They shouldn't have a lot of paresthesia or nerve issues. Um, and then, of course, we'll monitor like the incisions, small chance of infection, things like that. But that's on the low side at that point. So those are probably the most important things. And I'll talk to them about, activities and what they've been doing and compliance with the sling. Um, so, I mean, that's probably what I'm looking for at the 4 week mark.
And your initial evaluation with them that first week, let's say between weeks 4 to 6, the first 2-ish weeks of rehab, what does that look like, Terrance? And does that differ depending on the repair, or because it's so early on, it's pretty much the same priorities and restrictions?
Yeah. So I am in the conservative group. So when I think about this, and we talk about some of like athletes having this done, where this is not a surgery that you see a lot of high level athletes have done. I mean, granted, we have seen, some baseball players that have maybe went for dive in the into second base, or fell on their arm outstretched into center field and tore the rotator cuff, or a soccer player, a goalie diving, but that's sort of the few and far between. Typically, these patients are going to be your middle aged, weekend warriors, recreational athletes. So there's really no rush to get them back on a field. They're not fighting for contracts. They don't have agents and GMs in your ear. So, as far as I'm concerned, if this doesn't heal properly, then I mean, it doesn't matter what we're going to do afterwards because the tendon isn't healed, right? So early on, I'm always in this max protection phase. First 6 weeks, we're protecting this thing at all costs. We know, I mean, if you look at some of the healing literature, I think that really supports what we do. And that's what I talk to my patients about is, they've done these studies either in rat models or baboon models where they actually repair the rotator cuffs. They look at healing at different time frames. And there's one study looking at baboons at 4, 8, 12, and 15 weeks. And when they do this at the 4 week mark, what they see is just like a fibrin clot, right? So at 4 weeks, that there's some sort of repair starting to happen. By no means is it healed. At 8 weeks, they start to see a little bit of collagen formation. So collagen starting to align, but again, not healed. It's not until 12 weeks where they start to see some of those arterioles and blood vessels that are more prominent in the tendon. And the repair process starts to look more mature at 12 weeks. And then again, at 15 weeks, that's when those Sharpie fibers are present. So for me, it is critical that before 12 weeks, like we are controlling this, we're protecting it. So early rehab for me, that first, when I see them at 4 and progression to 6 weeks, we're working on some sort of postural exercise. And it's really more of a continuation of what they were shown by the physicians and the staff. So scap retractions, just standing up tall. I'll have them just active elbow flexion. Again, not trying to contract the bicep muscle, but trying to get a little pump at the elbow, keep the elbow loose. Hand and wrist stuff like your classic hand pumps, active elbow, wrist flexion extension. And then I'll review with them a passive elevation, a standing passive elevation, where they're essentially holding the elbow of the affected side with the unaffected side and just bringing it up to 50, 60 degrees. When I work with them at that point, so at 4 weeks, I personally on the table like to get them to 90 degrees of passive flexion. So I'll do a lot of hands-on stuff early on, manual work. We'll work on light joint mobs, like grade 2 joint mobs. I think that moving that joint around will help bring nutrition to the joint and actually helps them feel more relaxed. And you'd be surprised how much motion you would gain by doing some very light joint mobilizations and soft tissue work. And I think that's sometimes lost early on, where I think some clinicians think that, just stretching, there's a mistake I made early on too, is I would take their arm, I'd try and stretch. I'm like, oh, you're only 70 degrees, let's push harder. And I've slowly learned over the years that less is more. And just by doing soft tissue work and some scap protraction, retraction, and neuromuscular exercise for the shoulder blade, that you actually gain a lot more motion doing that than trying to force someone's shoulder. So first 6 weeks for me is essentially completely passive, focusing on posture. You'd be surprised. And again, this is something I've been surprised over the years that, you take for granted how easy it is to pull your shoulder blades back, but you have a patient, you ask them to actively retract their shoulder blades, and some just are not capable of doing it. And after sitting in a sling for 4 to 6 weeks, that sling's going to pull them forward. So they have even harder time trying to retract or even just come up into a neutral position. So yeah, I would say the first 6 weeks passive, and my goal for 6 weeks at the 6 week mark is to try and get them out of pain at rest. And that's it. So I just was talking to someone the other day and they're like, yeah, they just had their cuff done. And their colleagues were telling them like, oh, get ready for the most painful experience of your life. I had mine done. The whole process is painful. And I asked them like, this should not be painful. So I don't know where your colleague went to rehab or what they were doing, but like if you're in pain throughout your rehab process, something just isn't off. Something's not right. Like I'm trying to get you out of pain. I want to modify your activities at home. I want you to be out of pain. Pain to me is the body's warning sign, like something's not right. And I'm trying to get you to heal. So if I'm trying to promote healing early on, but you're in pain the whole time, I'm probably not promoting healing. Like this thing is getting irritated. So getting them out of pain for me is probably number one, getting them comfortable.
That standing position you mentioned where they're holding their elbow with the other arm and they're raising it to
Yeah.
about 50 or 60, you're on your own moving their arm in supine closer to 90. At home, do you have them do that supine where they're grabbing their wrist with the other arm and bringing it to 90, or are you just having them stand, assist, hold the elbow and go to about 50 or 60 degrees?
Yeah. So I also have trust issues, Chris. I don't trust my patients. So I until I'm confident that they're beyond 90 degrees supine, I don't have them do it on their own at home. So when they stand, I think they can very easily stand and find a position where they're holding under the elbow and they're just assisting the arm up and down. I tell them not to go to or above shoulder height. So at home, if they're doing that for me, I'm confident that they're getting some sort of movement in the glenohumeral joint. So they're trying to circulate some of the fluid, promote nutrition, and then when they come back to me, then on the table in a supine position, I'll bring them up to 90 and I'll start working them from 90 to 120 ish by 6 weeks. So if they're only at 90 degrees, if you watch your patients, I mean, a lot of them will struggle somewhere around the 90-degree mark, but when they're at like 110, 120, then I'll give them that exercise at home. I don't want them to work much below 90 degrees because that to me will actually engage the cuff. So a lot of them will ask, well, you let me go to 120 on my back. Why can't I do it standing up? On your back, gravity is assisting you. It's not fighting you, right? So when you're standing up and you're even as assistedly bringing your arm up over shoulder height, those muscles are going to engage and you're fighting gravity on your back. After 90 degrees, there should be minimal activation of your supraspinatus because gravity is really bringing you back. It's not the muscles. And they're very protective early on because they've been in pain for so long. So letting go for some of those patients is difficult. So until I'm convinced that they can relax their arm and they're doing it properly on their back and they have that, they're beyond 100, 110 degrees where they're actually able to move like 6+ inches on their back, then I don't give it to them at home. Because I think there's so many different variations that people wind up coming in with that I don't like. And another pet peeve of mine also is when they bring their arm up and down from that, supine in the supine position, that their arm is straight at their side and they keep it straight and bring it all the way up. I like a bent elbow to shorten that lever arm. When the arm is straight, it's a long lever arm and people's arms are heavy and it puts a lot of stress on the rotator cuff. So I'll make sure that they're bending, keeping their elbow bent, assist it straight up overhead, and then start working into that scapular plane, that shoulder elevation supine. So yeah, I'm pretty particular with what I let them do at home, what I don't, and until I'm confident that I've watched them enough where they're going to do it perfectly and not create more irritation, then I'll send them home with that.
And if they are having this persistent pain through 4, 6+ weeks, what are the things that are your next steps? And when do you decide I need to bring this up to the surgeon?
Yeah, so I think, anytime I've got a gut feeling that something's off track, I'll definitely talk to at least the PA for the doctor. I'll just let them know like this person's on my radar. A lot of our doctors will see their follow-ups somewhere between 6 and 8 weeks, so they get their hands on them. But if we need to intervene sooner, we definitely do that. Another nice part about working where we work is very close communication. I mean, all the docs are right upstairs for the most part or across town, so we can get in touch with them. But I feel like I've seen enough of these now where I know how you're supposed to trend. So if we're not, and that's why I keep things pretty light for the first 6 weeks. So we're not doing a lot. So if your pain is increasing and we're not really doing a lot, that to me is concerning. So what I do is I dive a little deeper into what you're doing at home. So I think things that can irritate you at home, there's literature published on just ADLs at home. So there was one study, I don't know if it's 2010 or so, that they looked at brushing teeth. I think it was brushing teeth, typing or writing, and drinking, and showing that drinking actually produced more than that 15% NVIC threshold. So it was up in the 20%. So versus typing and brushing teeth that were lower. So if they say, yeah, I'm using this arm to drink, or I'm using this arm, I take it out of the sling, when I'm home and I walk around the house, or sleeping is a big one. So I'll ask them how they're sleeping, sleep positions, because over the course of 4 to 6 hours, if you're sleeping in a bad position with that arm, it can cause a lot of irritation. So I'll try and make sure that we modify their ADLs as much as possible. Then you get those. I mean, at least in New York, we get those. Well, all right, the doc said I can get on a bike, so I'm doing 7 Peloton classes every day, and I'm standing like, listen, we have to modify all of this. And I think that's where education's key. So day one for me, I am drawing on the table. I'll Google images. I'll tell them to go YouTube, rotator cuff repair, so they can actually visualize what's done. Because once those portals heal up, I feel like people forget very quickly what was done in the shoulder. And you have holes drilled, anchors drilled into your bones. You have sutures around there. You might have had a bicep relocated, like we talked about, a bone spur shaved down. Those things hurt. And those things have to have time to heal. So if we don't give them enough time to heal and you're in pain, that to me is not a good thing. And then also, if we can't modify that pain, if we can't get that pain to go down, then the physician's going to come in anyway, and the physician's going to start running other tests. I think one thing to look out for, which has sort of crept up on me in the past, is some nerve involvement from the neck. So I sometimes overlook the neck because I'm sort of like laser focused on the shoulder. But I do think the neck over time has caused, whether it's from the nerve block that they get from surgery, right, that can irritate nerves, or just from the sling position, the compensation you have in the upper trap. So I think sometimes when the nerves get irritated, that they can create pseudo shoulder pain. So when someone comes in, like, I've got sharp pain down the back of my shoulder blade. Now to me, that's immediately neck, unless, told otherwise. And if someone has pain that's coming down the arm, past the elbow, again, that's referred pain. The rotator cuff's not going to refer pain below the elbow. So then there's like that nerve component that I'm always thinking about as well.
With the initial evaluation or the first few weeks, how often or how commonly do you discuss the why we are being so conservative? You've kind of discussed how you'll elaborate on that and pull up videos or write things out, but do you discuss these average re-tear or failure rates early on to instill this is significant and this is why we're being very slow and cautious?
I try not to unless I really want to scare them. And I feel like I do a good enough job scaring them, because you pull up some of these re-tear rates and it's quite alarming. I think, anywhere from 10 to 94% you could find in the literature from re-tear rates. Obviously the 94%, most of them are somewhere between like 10 and 50, but that 94% are like those massive repairs. So if someone has a massive repair, yes, I will make sure that they know that there is a risk of repair on the early side, especially if they're not compliant. A lot of those will re-tear early, as you see in the literature. But yeah, I mean, I think it's important to understand. I even think from like the clinical standpoint, like, why are there so many re-tears in these patients? And from our standpoint, I knock on wood, I don't see a lot of re-tears. And I think a lot of that has to go into, I mean, one, the surgeons that we work with, and the selection process, the type of repair. And then I think the rehab process is a huge part of it. So I think it's just common nature that everyone you talk to, like, oh, rotator cuff repair, the most painful process I've ever went through. I'm thinking like, this, it really shouldn't be that painful. And I don't know, maybe rehab is part of it. Maybe it's not. Maybe there's a whole, slew of different contributing factors. But yeah, I mean, we don't have a good grasp on why these re-tear, but there's a lot of them, and I think what's shown in literature are that if you have a high BMI or older population, we know the older ones are more likely to tear. And there are papers that show it based on the decade. If you're less than 50, they show 5% chance of re-tear versus, if you're north of 80, then there's a 35% chance of re-tear, right? Tear size. So if you have a small rotator cuff tear, you're less likely. If you have a large rotator cuff tear, you're more likely to re-tear. If you're a smoker, type of repair, sort of a lot of different things, socioeconomic factors, work comp status, work comp claims. So I think understanding for the clinician the re-tear or the poor outcome predictors is important, because that'll help you dictate the speed of your program. And coming out of school, I think having a set guideline was helpful for me. But then I think understanding, one, that there's a time component that we can't speed up, as we know from the healing component, but there's also the criteria that we need them to achieve. So having a general guideline is important, but understanding, how to modify those guidelines is even more important. That's what's helped me out. So yeah, if I have an older individual with a large to massive tear that has a high BMI and they're a smoker, well, I mean, my 6 week might turn into 8 to 10 weeks. We might keep it conservative for 8 to 10 weeks. So I think knowing what the outcome data shows can help the clinicians sort of modify their program, so we can make it a little more individualized.
Now let's jump to, they had their second follow-up with their surgeon and they're discharged from the sling, typically around that six-ish week mark. Like you said, there's other instances where either they're in the sling for longer or you're being more conservative. But let's say on average around this 6 week mark, what do things look like from you now on the rehabilitation side on educating them, now that you're out of the sling, let's still be cautious of XYZ? How do they start to live their life without the sling? How do you go about that conversation? And then what are the next, let's say between weeks 6 to 8, what does that rehab process look like?
Yeah, so I'll even group it 6 to 12. So to keep it simple, 0 to 6, now that we're 6 to 12, sling essentially is off. I'll tell them that they can start doing things at home with their arms below shoulder height. So writing, typing, washing their face, bringing your head down to your hands, wash your hair. So the things with the arm below shoulder height, I tell them they still are not able to bring the arm away from the body. So no reaching, no going overhead, no, going to the backseat of the car. So we want the arm to be pretty close to the body, but they can start using their hands more. As far as exercise in the gym, still just bike, nothing outside of bike. And then the rehab process now, I'm starting to, from that 6 to 12 week mark, I'm starting to do a little more from a range of motion perspective. So now we're going to transition from passive motion. Now we'll have them on their back doing like their, as hopefully by 6 weeks or somewhere around 120 or so. So they're doing the active assisted with their other arm. Moving towards 8 weeks, I'll give them, a mobility stick, and we'll start to eliminate, and still in the supine position, some of the assistance from the other side. So now we're going active assisted, and then progressing towards 12 weeks where we're going to have them do fully active. So my number one goal at the end, so by 12 weeks, my primary goal is to have full active range of motion. That's it. I don't want you to be strong. You're going to be weak, but I want full pain-free active motion. And if I'm there by 12 weeks, this whole thing is a success.
Can I get a clarity on that? Full
sure.
active range of motion, standing with overhead flexion, or in all planes of motion?
Yeah, I like full active motion in all planes of motion except for reaching behind the back. So that's going to come back. So that internal rotation behind the back come back a little slower. So at 12 weeks, I know what our surgeons are doing. They're going to come in, they're going to have them raise their arm up, they're going to have them put their arm behind the back. So if they can get just above the belt line and they have full external rotation, full flexion, we're good. And that's it. So if your patient, because then we want to move on to strengthening after that. So if your patient doesn't have full motion, I would have moved to strength, because they're just going to make them tighter. So I want you to progress. We know that at 12 weeks, things are healed. So we don't want to overload it for that first 12 weeks. So from a range of motion perspective, my typical progression is supine on the table with assistance from the other arm. Then we go stick on the table. Then I'll gradually increase the elevation of the table. So now we'll start to work against gravity a little bit. So we incline the table. After that, somewhere around like the 10-week mark, I'll go to wall slides. I don't like wall walks. I feel like it's a little funky on the shoulder. So I'll have them towel on the wall, usually both arms at the same time. So they're not leaning or compensating one way. So 10 weeks, generally sliding up and down with contact on the wall. At 11 weeks, I'll have them slide up the wall, lift the arm off, come down without the wall. And then by 12 weeks, they should be able to very cleanly elevate the arm. And that's what's worked for me over the last 10, 15 years. It took a little fine tuning, but I think that's a progression where we gradually incorporate gravity. We use assistance supine, and we use some assistance standing, and that has allowed them to not overcompensate and not have altered mechanics with reaching. So I like them to be perfect on the table. Then we get them standing, perfect motion standing before I even load. So that's my range of motion progression during that time. And then we get into exercises, right? So when is it good to start loading the cuff? And there's plenty of papers that have been published on like EMG activity and MVIC of cuff. And I sort of take that with a grain of salt. I've looked, I think Edwards maybe had a paper in 2014 or so looking at all different exercises and what was acceptable at different time frames. And they'll say, that first, early phase, no more than 15% MVIC, then moderate phase, 15 to 30-ish. And that early phase, more or less passive exercises, right? So they talk about the pendulums. They talk about like a forward bow and just let the arm hang. They talk about some like very light slides on the table. And those are all some of the things that I might incorporate. But for me, it's more about like, when can you start loading the rotator cuff? When can you start internal, external rotation? So I personally start that between 6 and 8 weeks, depending on the person and that patient. And I will do isometrics first for internal, external rotation. And then by close to 10 weeks, I'll start to move to isotonics if it's a small, medium tear. We'll do rows, so like band rows, and do that's close to the 6-week mark. They're doing band rows, and they'll also do shoulder extensions with bands. When I cue them on the rows, and this is what I think is also important for therapists to understand, like you might see in the literature, I think of that particular paper, the rows were like in the moderate exercise group. But when I have my patients do rows, it's light band, so it's like 4 pounds of resistance, and it's more of a scap retraction. I don't even call it a row because then people start getting aggressive when they hear like row. So scap retraction, bring the elbows back to the plane of the body. Once your arms, we're not going to extension. We want to avoid extension, but I'll let them start to move against a little bit of resistance. And I think for them too, it makes them feel better, right? Because we're going from squeezing the shoulder blades, now we're giving a little resistance. Shoulder extension, same thing. The arms are straight, about 10 inches in front of the body. And they're just coming down. Again, another scap exercise. Prone rows on the table, just trying to engage some of these posterior scapular muscles, your mid traps, your rhomboids, and trying to activate that. I mean, we know how important the scap is in protection of the shoulder and as, essentially the foundation of that shoulder. So your scap muscles have to be strong. And without isolating the rotator cuff at this point, there's a good way to work the scap. And then during this phase, we'll also go isometric IR-ER.
I have a few questions.
Yeah.
Let's start. You just said isometric IR-ER. That initial, you said within, I think, believe 6 to 8 weeks, you'll introduce that. What does that typical prescription look like? Is it the standard, like against the doorway? How does that look?
Yeah. So for me, it starts on the table. So before I let you do something on your own, I want to make sure that you feel good doing it. So usually supine on the table, towel roll under the distal humerus, elbows flexed to 90 degrees. I'm just doing some light IR-ER rhythmic stabilizations. And if you think about it, everyone's like, oh, why do you do that so early? I'm like, if you think about it, if you had a supraspinatus repair and we're engaging your subscap or engaging infraspinatus isometrically, it really shouldn't produce that much tension on the subs or on your supraspinatus. And you'd be surprised, even if you have a subscap repair and you do some light work at 6 weeks, it's actually okay and they feel good tolerating. I mean, at some point we need to start loading this tissue. That's going to help, align some collagen. We know from like Keith Barr's work that load is good, but it's got to be a gradual progression of load. So I'll start some light IR-ER, and I'm not crushing them, right? So it's like 2 or 3 pounds of IR. I want to feel that muscle contract. So what I tell them at the 6-week mark is, we're not trying to strengthen you, but we're trying to reverse atrophy. We're trying to prevent more atrophy from happening. I want to wake that muscle up at this point. So at 6 weeks, I'll start on the table. And if I think they can tolerate, 3 to 5 pounds of pressure and feel okay, then I'll have them stand and do it. I personally do not like them doing against the wall. I think there's too many compensations. It's not saying that it's wrong to do, but that's just over time. I turn around for whatever reason. I look back and they're like leaning into the wall, or God knows what they're doing. Their whole body's like laying in the wall. So I feel like if I have them do bands, I like the band walkouts. You position them properly, towel under the elbow bent to 90 degrees, stand up tall, step away from the band. So I could be anywhere in the room and watch you do that exercise, and I know if you're doing it properly. Hand is lined up with the elbow, so we're not letting it drift in or out. And if they're stepping too far and that hand starts to drift, then I cue them to step back. And I think, the education is important. So submaximal, no pain, and just generate a little bit of resistance through the arm. I make sure they understand that external rotation is going to be a little less tension, and they quickly realize that when they try to be aggressive with it. But same thing, I think the band walkouts isometrically for me has worked out really well because I can watch them do it and then they understand it. And I think at home also you have them do home exercises, and something about putting a band in the door versus just leaning into a wall for them seems a little more exciting. They feel like they're doing a little more. But yeah, I've moved completely away from the wall push, but people still use it successfully.
Then that 8 to 10 weeks when you're introducing isotonics, will you essentially keep that standing banded variation and just go into IRER with a light band resistance?
Yeah, exactly. I tend to control them from 0 to 90 also. I've noticed that as people externally rotate beyond 90, they've had some, or they've complained of some soreness. And I think if you do, rotate beyond 90, if you think about, the supraspinatus and how it attaches, that there is excursion in internal external rotation, although it is a elevator of the arm and a initiation, or it helps initiate abduction. If you rotate too far one way or the other, you're still going to stretch portions, the anterior or the posterior portion of the supra. So I do caution them to go just 0 to 90 degrees, not beyond 90. I don't want to increase the strain on that tendon. I mean, the goal for me is to just get that subscap or the infra teres working with those exercises. So I'm very particular on how I educate people on those exercises and how I have them perform them.
From educating them on frequency of at home, let's say on average you're seeing them 2 times a week, and you're doing these either the walkout isometrics or the isotonics, how often are you having them do either of those on their own during the 6 to 10 weeks?
I tell them twice a day as long as it's separated by 6 hours. So again, I think that's the loading principles. We've been looking more of this Keith Barr work on load and through the tendons, where, after 6 to 10 minutes of load to a particular muscle or tendon or ligament, they need about 6 hours off. So if you have time to do it in the morning and then you do it again in the afternoon, give me about 10 minutes of the exercises, then I'm good with that. And then if I tell them, if there's a day you're sore, take a day off. You're better off not working through soreness than you are pushing this through soreness, especially in those first 12 weeks. Again, by 6 weeks, I want them to be pain-free with daily activities. And by 12 weeks, only thing I'm looking for is them to be able to move their arm without pain. That's all. I don't think we're looking for much, but I need to get them to those 2 big checkpoints.
You mentioned that very logical progression of shoulder flexion throughout the weeks. Do you find that if they can go through all those checkpoints, that you really don't have to hit hard on abduction range of motion, it's just going to come naturally? Or do you also have logical progressions for abduction and external, internal? What about these other planes of motion?
Yeah, so I've never really had a problem with abduction. A lot of people ask that question, like, why don't you work abduction? And I see other people are doing like stick out to the side. And I mean, there's so many things that I see and I've seen people do over the years. I'm like, oh, that just doesn't look right. Like, I can't imagine that being beneficial. And we, one conversation we have all the time in the clinic is about pulleys, right? So you watch people do pulleys, and I'm like, for me, pulleys and pendulums are 2 things that sort of get me going. Where again, it goes back to people not doing them properly. Like, I don't think there's a problem doing them when they're done properly. I mean, pendulums, there's a paper, I think 2010, there's a paper on pendulums showing activation during the pendulum exercise. And when they're done properly, no problem at all. when large incorrect pendulums were done, it exceeds that 20% threshold, the 15% threshold of MVIC. So, I mean, if I challenge you to tell your patients, try it. Tell your patients go do pendulums, come in and then show me how you do those at home. And it is wild, some of the things they do. They're standing, arms flying around. Like, geez, like this is not what I showed you or not what we talked about. So I've eliminated them from my progression at all costs. So pendulums are gone. And then pulleys, like, wow, I just like watching people fight through like some of those compensations of pulleys. I'm like, oh my God, this is just doesn't look good. So I've eliminated them also from my program. Not saying that if done properly, it's not helpful. It's just things that have not worked for me in the past. Sorry to go off topic. What was that question? Did I even answer your question?
Yeah, the abduction you
Oh, yes,
essentially
yes, yes.
answered, and then external or internal rotation range of motion.
Yeah, so external rotation, I feel like a lot of people stretch too much in external rotation. So same thing, like I'm a huge proponent of hands-on. First 12 weeks, like you have to have your hands on these people. And I think I can get a very good sense of whether or not you're going to be stiff just from my joint mobilizations. And early on, like I mentioned, I did my manual certification through University of St. Augustine. They're a very big proponent of just being able to mobilize a joint or assess joint stiffness. So very early, I feel like from like the 4 week mark, I know if you're going to get stiff or not because I can check your joint. I can assess your joint mobility. So for external rotation, passively, I'll do it passively with them in the clinic. And if they're hitting my checkpoints, if I'm at 30 degrees by 6 weeks, and if I'm at 60 degrees by 9 weeks, I'm okay. And I would rather you not do that on your own because same thing, right? I think if you've seen enough of these, you know how people move into external rotation. All of a sudden, you turn around, their elbows straightening out, the arm's not moving, there's no towel underneath. They're just creating this extra pain that I don't think that's really quite necessary. And then external rotation also, there was a paper that I saw recently showing that at the 6 week mark, if you have less than 20 degrees of external rotation, that there was a 7% chance of re-tear. If you had greater than 20 degrees of external rotation 6 weeks, there was closer to 15% chance of re-tear. So maybe we want to keep them slightly stiff, slightly longer, because I think people on their own can be way too aggressive with that. From an internal rotation component, around 10 weeks, I'll have them start putting their arm behind their back. Mostly because I know at 12 weeks when they see our surgeons, they're going to put their arm behind their back for them, whether they like it or not. So I try and do it first in rehab. But my goal by 12 weeks is to have them just above their belt line. So typically what we'll do, very simple, towel pass behind the back. Hold the towel in the affected arm, pass it behind your back to your unaffected side. And first, we're just trying to tell them just go up towards the middle of your belt line. Don't have to get above it. Just go. That should be your target. And then once they're above the belt line, then I'll have them start working up towards their opposite shoulder blade. I don't do a lot of aggressive stretching here, but I will have them progressively stretch over time. So I tell them same thing with all their other exercises. When you're stretching, you're going to feel there's a range of stretch, right? Where first, whatever degrees, you're going to feel nothing. Then you're going to feel some tension. And then it's be slightly uncomfortable where if you push any further, it's going to be painful. So you need to find that window or that zone where you feel the stretch and you know that if you pushed any further, it's going to be uncomfortable or painful. That's where I want you to stop before the pain starts. Because I do think if you don't take it to the tension or to that first point of resistance, you're not going to stretch. So you're really not getting much out of it. But if you push too far, you're going to cause irritation. So we want sort of fine tune that window. And I need my patients to understand where that window is. And they'll realize if they stretch too much or if they push too far, especially for internal behind the back, they're going to get sore. And they actually will get tighter when they get sore. And they realize that. So we try and really dial in on that window where they feel the stretch, but they're not pushing too hard. But yeah, I do think abduction comes back on its own. Will guide external rotation. Internal needs a little more work because we wait a little longer for it.
Is there anything else you wanted to touch on between the 6 to 12 week mark that we haven't?
No, I think 6 to 12 weeks, you still keep it simple. I mean, knowing that this thing is healing for the first 12 weeks, we can't overload it. So we don't do pressing, we don't do overhead work. Outside of, range of motion exercises, we're not really doing much above head or over shoulder height. So really within that first 12 weeks or from 6 to 12 weeks, I'm trying to perfect scapular movement. So we'll work on protraction, retraction, make sure your scap's working properly, probably engage the core a little bit, maybe thoracic spine, but then working through your isometric and isotonic internal external rotation exercises, knowing that at the 12-week mark, now I want to jump into strength. So I need to set you up for that. So if we're going to jump into strength, I need you to have perfect motion by 12 weeks. So I really think about fine tuning it and trying to modify things as much as possible to prepare them for that.
We're not going to go all the way through the full stage of by the time they're discharged, but let's, before we finally wrap things up, what does that 12 to 16 weeks introduction to strength typically look like for you? What are your, outside of the loaded IR, ER isotonics, where do you introduce some type of floor pressing or other upper
Yeah.
extremity based exercises?
Yeah, so working in 2 rows. So with like the cable columns, we're doing pulls first. So we'll do rows and lat pull downs, and those will start, and then light floor press. And I like a floor or blocked press for our patients. I educate them even when they go back to full that we're doing some sort of block press, so the arm's not coming down behind the plane of the body. So that puts the cuff in a biomechanical disadvantage. So blocked press is okay. And then after that, usually around like 14 weeks or so, we'll start like a standing press, maybe a cable column, single arm press. And then overhead starts around 16 weeks for me. And that's really the last thing I get back to. When we do overhead press, I usually keep them like that landmine position, or we'll have them hold like one of those weighted balls, or just like dumbbell, one end each hand straight up overhead, so that they have the elbows in front of their shoulders. I think that's a big thing for our patients, trying to keep them in that scapular plane, especially as we start the overhead progression. And again, for a push progression, 14 weeks or so, I'll have them do like an incline. I don't love the wall press. I mean, people, as they get closer, they just like, again, don't do it properly. So we'll set up the bar on like the rack at a higher level, and it will gradually lower that towards like a table height or a counter height. So they'll do like push-ups into a bar, like on a rack, and then eventually get down to like a counter height. And then at home, I'll tell them they can do like some counter push-ups at home. Um, Depending on what they're getting back to. I think also for your patients, understanding what their goals are very, very important, right? So if we have, the outlier, the overhead athlete that's going back to diving to bases, or a soccer goalie that has to dive, you've got to progress them towards those exercises. But if you're having someone where their only goal is really to go back and play like recreational tennis or doubles tennis or pickleball, or something that doesn't demand like high level exercise. If they don't want to go back to doing push-ups, don't have them do push-ups. I think functional strength is important. So even like an incline press or a counter press is okay just for some functional pressing strength. But I would never take that patient then have them do 3 sets of 15 modified or full push-ups, because that's not a goal of theirs. They don't need to do that. And I think that there's a risk of doing some of that stuff too early. And overhead also, same thing. If their goal is to just return to like normal life or gym activities, then we're not going to do heavy overhead press, but we need them to have functional strength, reach up into a cabinet, to take a bowl out. I mean, those things are challenging for somebody. So making sure you match the level of rehab with the demands of the patient, as long as they're realistic demands.
For the more common patient receiving a rotator cuff repair, this, as you said, middle to older age adult, maybe they're active, maybe they're more sedentary. What are you finding on average timelines of discharge? And going back to the things like you said, doubles, tennis, pickleball, golfing, what do those average end timelines look like, Terrance?
Yeah, I'd say somewhere around 6 months. So, and again, for me, right? So they're healed at 3 months, and at 3 months, we're starting to strengthen. So, somewhere around like 5-ish months, like if they want to go and like chip golf balls and start working through a golf progression at 5 months, with, return to 18 holes, somewhere between 6 and 8 months. And then I'd tell them feeling really good around like the 9 month mark. But 5 to 6 months, we'll let them start like an interval progression. You go out and you just start hitting some tennis balls. Obviously, you're not serving at that point, but maybe ground strokes only. If you're going back to golf, get the wedges out and start with some wedges, and gradually over the course of like 3 weeks, they'll work up their bag. Um, But again, you've got to display to me that you have full motion. You've progressed through a strength program where, we've matched demands for golf. We're doing some rotational exercise, whether chops or lifts. We'll have you swing like speed sticks or something in the clinic just to make sure you look okay swinging, or tennis, something similar. But between 5 and 6 months, you should be fine starting that. And then full return, they'll always ask, when am I going to feel normal? Surgeons will say 9 to 12 months, but I think close to the 9 month mark, you should feel pretty good playing your sports.
In an ideal world, if you had for those type of adults, if you had a discharge testing criteria or things you'd recommend clinicians test before patients are finally discharged, what would you recommend, or what do you do in your own practice?
This for a non high level athlete?
Well, we could do both. It's up to you. We could do both. Yeah.
I'd say for high level athletes, I'd want for the rotator cuffs, again, depending on what they're getting back to. So if it's a thrower that happened to have rotator cuff repair, we'll do limb symmetry. So I'll look at internal external rotation side to side. In order to start your sport, we're looking for 10% side to side. To return to your sport, it's got to be north of 100% side to side. So restoration of strength, full shoulder motion. Contact athletes, so a football player having a rotator cuff repair, we would probably do close connection upper extremity test, push-up test on force plates, looking for symmetry side to side, as well as like an ASH test on force plates side to side, looking for within 10%, typically 10% side to side. And then for recreational athletes, I typically don't put them through the objective testing, but what I want to see is a clean progression through your exercises. And for me, it's, I hope I do a pretty good job of matching the demands of your sport. So I have a pretty good feel for where you're at if you're going back to recreational stuff, but I typically don't put them through the handheld dynamometer max testing or the push-ups on force plates, things like that, depending on what they're getting back to. So it's a little more stringent with our pros. Because their demands are going to be a little higher than your 55, 60-year-old having the cuff done. Now we're doing max strength tests. And the last thing I want to do is hurt you or set you back because I'm doing a test that probably is not necessary for what you're getting back to.
Yeah, that totally makes sense. Any other thoughts or recommendations you have for clinicians, particularly within that first 4 to 12 to 16 weeks that you don't think we touched on?
I just think going slow. So over the years, when I started, I thought that the further I push someone or the harder I push, the more progress we make. And the biggest lesson I've learned is that less is more early. So it's hard to comprehend, but if you force someone's motion, you think you're going to get more motion, but you probably going to create more irritation, which is going to create more stiffness. And they're not going to trust you. They'll be, more likely to guard. So by pulling back a little bit and working more on joint mobilizations and, rhythmic stabilizations and scapular mechanics and scapular neuromuscular work, you actually will help them gain more motion. These rotator cuffs, they really shouldn't get that stiff. And with all the literature we read, even if they were stiff, a lot of that stiffness is transient and resolves close to 3 to 4 months. So I'm always on that slower side of things because I'll tell you what, if you are aggressive, and there's this big, debate now between accelerated versus delayed rehab, and should we be accelerating these people and moving them sooner? Of course, if you accelerate rehab and you start moving them actively week 2, they might have improved range of motion early on, but in every paper I read, the risk of re-tear is higher. So what is the cost? And you're going to get the motion back. So what is the cost of that? And for these patients, we know how revision rotator cuffs work. If we talked about the outcomes after primary cuff repairs, like you think revisions are better? And then if you have a massive tear, that's got to be revised. Guess what? Your options are limited. You might have a total shoulder put in now. So I never in my practice want to be the person or the reason that your rotator cuff failed, right? So I am not going to put you in a position. I want to be able to look back and say, listen, we did everything properly. We waited till you were pain-free. We got your full motion back passively, then actively. Like we had a systematic progression to what we did. If that outcome doesn't turn out the way we want, I can look back and say, and when I look back, at people that fail. I'm like, did I do something? Was there something I could have done better? And I don't want there to be a reason that on my end that you fail. So I will always go slower early on. And by 12 weeks, then we'll start strength. And in all honesty, I'll probably see 50 plus of these a year, at least 50 plus of these a year, and they do well. And we have some of those come in that are all flared up and irritated from other centers. And I'll tell you what we do, like we just pull back on everything. Like I get rid of your pain. I don't keep forcing it. We make sure we get rid of your pain, whether it's anti-inflammatory, some might have a course, whatever it is, and then gradually take you through the same progression, restore pain-free range of motion, restore strength. And I don't think it's really not rocket science, but I think as you see more of these, you understand the progression and what people tolerate and what they don't. And it's really activity modification and then gradual progression through range of motion and strength, and then match the demands of their exercise, and they're happy.
Yeah, that was all great. I think that's a great place to stop. I know there are some things that you wanted to discuss or promote upcoming works and projects of yours, so I'll let you dive into both of those.
Yeah, thanks. I mean, this is great talk. I mean, obviously, most of what I've seen is shoulder and elbow, and I love getting that information out. My Instagram page is Life After the Knife, and there's a ton of information on there about literature and everything else. And recently, this actually, times well. We just started a new company called ProArm, and it's proarm.co, which is all continuing education offerings for the upper extremity. And our first course happens to be a deep dive into the rotator cuff. So a lot of stuff we talked about in more depth is 2 CEUs, and that can be found on proarm.co. So we've got a lot of stuff coming out, and really just excited to help everybody get to where I'm at just a lot faster and learn from my mistakes, and really start a community where we can work together to make sure we don't increase those re-tear rates. We got to start bringing these numbers down.
Perfect. Yeah, we'll link that in the show notes. And I was actually looking at it earlier, and I downloaded that kind of guide that you all had for free, which was great. So
That's
very
awesome.
helpful. Yeah, we appreciate it. Anything else, Terrance, before we wrap it up?
No, I mean, thanks for having me on. Feel free to DM me on Instagram or LinkedIn, and if you guys have any questions. But definitely looking forward to continuing this conversation. This is really a great topic and something I'm very passionate about. I'm always trying to find a way to get better. So if there's anything anyone else does that I didn't mention, love to hear about it.
Awesome. Thank you, Terrance. We'll call it there.